Nigerians will actually tell you that I thought we should not be talking about COVID-19 at all. So if we hear one or two, to them they believe that there's a surge or something.
Well, that's actually incorrect. So the problem is the expectation that we shouldn't be talking about COVID-19 or at all. If people remember, we continue, even with the changing epidemiology and reduced numbers, we continue to remind people that it's not over until it's truly over. We might, even if cases go down and things are quiet, sometimes we don't know what the virus is doing. We are part of a global community. There's always the risk that variants may emerge from elsewhere that have increased capability to make people sick, or increased capability to be more infective or transmissible. So while we understand that the epidemiology is changing because more of the population is protected, both from a combination of vaccination and a combination of natural infection, until you actually bring the virus completely under control, or it sort of evolves like it happened with the flu, when the flu first occurred as a pandemic. We can't truly declare things to be over, but things will get better with increasing immunity and increasing population level protection.
Welcome back. If you just tuned in, this is The Conversation. We're reaching you from KAFTAN Television here in the nation's capital, Abuja. You just joined us, you're right on time for the interview. Our guest on the show today is Professor Ifedayo Adetifa. Mr. Ifedayo is an associate professor of infectious diseases epidemiology at the London School of Hygiene and Tropical Medicine. He obtained his medical degree at the University of Ilorin, Kwara State, here in Nigeria. He trained in pediatrics and child health at Lagos University Teaching Hospital and received his fellowship of the West Africa College of Physicians in pediatrics in 2005. You get to meet him and then hear a whole lot of good things about him. It's good to have you on the show, sir.
Thank you for having me.
Great. All right, now let's start with since you resumed office as the DG of the NCDC. Has it been for you? What are the challenges that you have to put up with? The losses, the wins that you've gone through?
Good question. It's been a challenging 1 year, as you'd imagine, of trying to settle in and to adjust to the demands of the position and, of course, the operating environment, which is different from where I've come from. But what's interesting is that the pathogens that we deal with do not care whether you've just come out from the cold or not. In that time, we've had to respond to Omicron coming into town. My first Lassa Fever season as the one responsible for a response. To deal with cholera, deal with meningitis, deal with measles, yellow fever, and of course deal with COVID, which was the ongoing pandemic at the time. So that made for a bit of a challenge, but I think one of the reasons why I took the job was to sort of rise up to that challenge of making a difference in the space. So it was a welcome challenge, and I think one that, with the support of the team here and leadership and partners, that once weathered that storm for the first 1 year. And I'm looking forward this year to implementing a strategy of growth and making us do better the things that we are meant to do.
All right, so I hear you say you've received support from the group here in the office. So how's it been for you? What kind of support do you get from the government? What kind of support do you get from the publics, Nigerians entirely?
Well, there's support from the government in terms of increasing funding, and of course support from those that are in leadership, in my leadership pathway, basically the ministers and Minister of State for Health, and even the Secretary to the Government of the Federation. So that's been, I have no complaints there. I've been had the opportunity to consult, to get advice, and be consulted and to also be asked for advice. I think the agency overall is one of those government agencies that has a relatively high approval rating from the public. There are still those there are still complaints here and there. Of course, we take on board constructive criticism and try and improve as the case may be. But I think largely we are trusted. We're a trusted government brand, and we hope and we continue to work hard to improve on that and to retain the trust of Nigerian citizens whom we serve.
All right. Now, a few days ago, most of the national dailies reported that the Nigeria Center for Disease Control has posted 35 new cases of COVID-19 for the last week of December 2022. 22 of the cases were recorded in FCT here, by 10 cases in Lagos, 2 in Delta, while 1 happened in Plateau State. So, and all of these infections were recorded between December 21st and 30th, 2022. Now, with all of these numbers, where do we first? I'm going to ask you 2 questions, and I'd like you to unbundle them in one breath. Now, with all of these numbers, where do we stand at the moment today? And why do we still have the spikes in the numbers?
We don't, starting with your latter comment, we don't have any spikes in the number. Actually, if you look at the pattern overall from November to now, the trend is downwards. There are a few cases. That's a 1-week period. The week after, I think we reported 13 cases or thereabouts, because for that period ending 31st December and up to 6th, and then the next period up to 6th January, there's a total of 48 cases in total for both in-country testing for people in the community and testing, the little bit of testing that still goes on for travelers. So that's not a spike. That's compared to the total number of tests done, that's less than 1% of tests positive.
Okay, but Nigerians will actually tell you that I thought we should not be talking about COVID-19 at all. So if we hear 1 or 2, to them they believe that there's a surge or something.
Well, that's actually incorrect. So the problem is the expectation that we shouldn't be talking about COVID-19 at all. If people remember, we continue, even with the change in epidemiology and reduced numbers, we continue to remind people that it's not over until it's truly over. You might, even if cases go down and things are quiet, sometimes you don't know what the virus is doing. We are part of a global community. There's always the risk that variants may emerge from elsewhere that have increased capability to make people sick, or increased capability to be more infective or transmissible. So while we understand that the epidemiology is changing because more of the population is protected, both from a combination of vaccination and a combination of natural infection, until you actually bring the virus completely under control, or it sort of evolves like it happened with the flu, when the flu first occurred as a pandemic. We can't truly declare things to be over, but things will get better with increasing immunity and increasing population level protection.
Okay, so you didn't answer the first question I asked. Where do we stand at the moment in terms of the numbers?
Yeah, that's what I said. I said that number, in addition to the number for the following week, which ended 6th January, brings us to a total of 48 cases in 2 weeks. So it was 35 the previous week, so we added 13 more in the first week of January.
All right, now, so if they are still, like you said, it is not over until it is over. So if you have to come into your office, you must always ensure that you adhere strictly to all of the safety, COVID-19 safety precautions. But now we see that you can even walk into any grocery store, in public places, even the airports, the safety, all of those strict measures have been relaxed. So why did we have to actually relax all of that measures?
Well, the safety measures were relaxed in response to the epidemiology of the disease in the country. If you compare this time in the last quarter of 2022 to the last quarter of 2021, the picture is different. Okay, in November or thereabouts, Omicron emerged. The country had its 4th wave. We had a significant spike in disease because Omicron, when emerged for the first time, was highly transmissible, caused a lot of infections. Thankfully, did not cause severe disease requiring hospitalization or result in a lot of deaths. But we had that peak. 1 year later, um, we've ramped up vaccination programs. We've had that massive population level infection. Population is better protected from SARS-CoV-2, which is the virus that causes COVID, and we are seeing a decline in cases, which means, typically what you would expect to happen if you take out emerging new variants is that first you worry about the disease in the whole population. As the population becomes immune or protected against the virus, the focus often then switches to just high-risk groups. Okay, so those who are at high risk for severe illness, either because they've got something wrong with their immune system, so either from cancer treatment or immunosuppressive treatment, maybe they are organ transplant recipients, or they have chronic underlying chronic diseases like diabetes and co. These become the people that you look after. It's some sort of similar to what happens in other places where those at the highest risk of flu are the 60 or 65-year olds and above, and they are typically targeted for vaccination every winter period just to protect them, compared to sort of the younger people and the children. So based on the epidemiology in the country, reducing cases, increasing protection, as at the end of last year, against the backdrop of what had been widespread transmission of the virus, we vaccinated over half of the population that are targeted for vaccination. Significant population immunity, even though we are behind on the target of 70%. So in response to that, the natural thing to do is to ease restrictions, COVID-related restrictions. But even with the easing of the restrictions, we still maintain and advise, if you belong to the high-risk category, please protect yourself, wear your mask, wash your hands, avoid crowds, make sure you get your primary vaccine series, get your first booster, get your second booster to ensure that you receive the maximum protection that is possible.
So what kind of education, sensitization do you send to the public so as to make them understand that even though we've relaxed all of these measures, COVID-19 is still there? Because we have actually did some street reports, and there's some people said, if I can go into the airports, especially the airports, and I don't need the COVID-19 the card that shows that I've been vaccinated twice, then it means we're COVID-19 free.
Well, that's, again, it's a misinterpretation of, and I think the messaging has been clear. Clearly, there's a need to improve on that. But the messaging following relaxation of the restrictions did not say COVID is over. In fact, reminded us that it's not over, but that based on the epidemiology, this is what to do. But to the extent, of course, we remove the things that were mandatory, because they also, of course, have impact on businesses, on the airlines and the like. But we still sort of maintained that we recommend adhering to public health safety measures in general, and especially if you are in the high-risk groups. We can't continue 2 years or 3 years down the line the same way as we did in the early days of the pandemic if there's no evidence to support us doing that, because restrictions make people uncomfortable. The reduced occupancy in offices, in businesses, meant that some people couldn't go to work. Some people couldn't, you couldn't have full meetings because there's a limit on capacity. And we got many letters from many people, institutions, asking for when would restrictions be eased back, because it's affecting business, and that they know that they've got significant or high levels of vaccination coverage among their staff and all of that. Even government at some point in time, the head of service released a circular saying that you couldn't come to work if you hadn't received your 2 doses of vaccination. So, and same thing with the issue of asking people about vaccination cards on your way out, even the airport. It was all aligned as part of government strategy to make sure that there's uptake of vaccines, and we move quicker and closer to a level where a significant proportion of the population is protected. If you're, as you would recall, the National Primary Healthcare Development Agency, who is responsible for vaccination, has implemented, scales 2, scales 3, which are all about scaling up vaccination and access to vaccination. And actually, in addition to doing the campaigns, are already working on transitioning vaccination to become routinely available along with other vaccines in primary health care, recognizing that you can't do campaign mode for the rest of time. It's at some point in time, you get as many people as you need to get vaccinated. More people will become eligible for vaccination as you go, but hopefully in the near future, all it means will be just you going to a health center and getting your vaccination along with just like the babies who go and get their jabs as well.
Okay, so now seeing that in 2021 we're neck deep into that pandemic. Now, would you actually say, would actually like you to answer if, are we ever going to go to that lockdown mode anymore? Because a lot of people are really agitated at the moment. So I'd like you to respond to that.
I need to choose my words carefully. It's very unlikely, is what I would say. If you're looking at theoretical possibility, you cannot say 100% that. It's very unlikely that would be required. The only conditions under which we can go back to the way things were 2 years ago when this pandemic started is if a new version of the virus comes out that we do not recognize, we've not seen before, all our existing protections have no impact on that.
Okay.
Then some of the measures that were previously taken can happen. But it's also very unlikely, even with the scenario that I described, because we have learned lessons from 3 years ago. If along with some of the lessons that were learned 3 years from this ongoing pandemic are, for example, global efforts to make sure that the next time we have an outbreak like this, there will be a vaccine within 100 days.
Okay.
Okay. So the world developed a vaccine in record time for this pandemic. It was a bit slow, but still in record time. Of course, that record time is misinterpreted by some to mean that corners were cut, but what they are not taking into account is that the process didn't start from the scratch to the finish. Is that there were things that were going on in the background, in the research and development field, in the background for vaccines that were then available to leverage on, giving the additional government commitment and provision of funding to give some assurance to vaccine manufacturers that made products come out quicker. And we can see that vaccines were very effective in disconnecting positive case from hospitalization and deaths. Yeah, so even when people still continue to have infections, we do not have anything like the number of hospitalized cases and deaths like we had early in the day in the pandemic. And it's a great achievement for global health. Yes, there are challenges about, there were things like, of course, the vaccines were not equitably accessed by people all over the world and all of that. But the fact that they came on stream allowed people to go from the extreme restrictions, which is to buy time so that your health system doesn't get overwhelmed, to then being able to now deploy medical countermeasures like vaccines and other things where they became available. It's a relatively good story for public health, and we would be, I think that it's unlikely that the world will not take those lessons going forward. So if we had, this is one of the reasons why we are tracking COVID variants, is that in the event, just in case, that there's so many changes and mutations that a new variant of concern emerges that is basically like to the population when Alpha, Beta, Delta came out, we will be able to deal with it very quickly.
Okay.
So we are definitely not going to be anywhere like we were in 2019, but we then sort of need to look at the scenario or our level of preparedness, assuming a completely new pathogen emerges. This is why you can't go to sleep or become complacent. The projections are that the world, including Nigeria, will be at increasing risk of pathogenic threats going forward for a host of reasons, and many of them will be pathogens like SARS-CoV-2, what we call zoonotic pathogens.
Okay, so I like the part that you actually touched on the politics with regards to the COVID-19 vaccine development, but we'll definitely go back to that. But now I need you to clear the air with regards, because you talked about the new variants, I need you to clear the air with regards to the new variants of COVID-19.
Situation with COVID currently globally is, to summarize, is that in some parts of the world we are seeing an increase in cases, an increase in hospitalization, an increase in deaths. If we summarize by region, the Americas, in a 4-week period, when you compare the last 4 weeks of the year to the preceding 4 weeks, have had like a 74% increase in cases, so North and South America. And this is translated to almost also about a 49% increase in deaths as well. Okay, for the Western Pacific region, this has been, which includes China and Japan, this has been like a 47% increase in cases and almost a 30-something% increase in deaths. Africa has gone the other way in general. We've had a 74% reduction in cases and a 43% reduction in deaths and hospitalization. In the case of China, China is making a transition from a zero COVID policy where they had full restrictions, lockdowns, testing, all of that, moving from that to a more open thing. So, unsurprisingly, when you do that, the virus is now being transmitted more widely across the population, and they are having more cases, more admissions, and sadly, more deaths. Okay, I say it's unsurprising because what this basically shows to us is that because of the long use of lockdowns and all in a zero COVID policy, as far as exposure and immunity to the virus is concerned, majority of the Chinese population, especially in the rural parts and all of that, are in the same place where the rest of the world was 2 years ago, when we were dealing with Delta and also, so that's what has happened. Now, because of the increased transmission and what's going on, the worries about, okay, new variants will emerge. Okay, and they do have some variants that have emerged, so maybe 7 and B1.5.2. But the good thing is, and we are waiting and looking forward to more data from China, but the good thing is that those variants they are currently seeing that's associated with the trends have been seen in all parts of the world in more than a year before. Okay?
Oh, really?
So, for example, the B.1, 1.5.2 was first reported in the US even in the late 2021. The US had deposited in sequenced and deposited in publicly available databases more than 50,000 genomes of that particular time. And this subvariant or Omicron descendant has been seen in Africa, has been seen by us already in Nigeria, seen in South Africa and other places where there's. So that gives us a bit of assurance that they don't have necessarily a worrying variant. It's just that the opening up is leading to more transmission of the virus across populations. Obviously, we need to continue to wait on China to share some more data so that the rest of the world understands what's going on. Now, in the case of the US, we have new Omicron descendant, XBB 1.5, which is different from what's seen in China. And it's now considered to be the most transmissible form of Omicron. Okay. So it was first detected in the US, I think, New York area in about October, and now it's the predominant variant. And then there are worries that, okay, maybe it may be more virulent, in which what we mean is that it may be able to cause more severe disease and then, of course, result in hospitalization and death, but that has not been proven. Okay, so just this week, the South Africans have now reported that they've actually seen XBB 1.5 in South Africa. But if you look at South Africa case, and that is from their samples from December that were processed.
Okay.
November, December now, there's no change in incidence of disease or admissions or deaths in South Africa. It's not been associated with any increase in the population, which is a bit reassuring because it also supports all of our collective assessments that our populations are significantly protected. The interesting thing is that in the case of South Africa, unless I'm mistaken, We actually have better vaccination coverage than they do.
Oh, really?
Yeah, but
Okay.
again, because there's been widespread natural infection and all of that, um, this is helping in some way as well. So that's the situation. There's a lot of discussion about China and all of that, but we take a risk-based approach. We look at where all of our risks are coming from, not where somebody says the risk is coming from. Cases have gone up in all these parts of the world that we have travel for, and therefore there's a risk of importation from everywhere. Or actually, the pathogen you are worried about importing is actually already with you, but not behaving differently because it's not winter here. We don't have a winter.
So maybe the weather is just
exacerbation.
being nice
So
on us.
yeah, so that's the point, and we are keeping an eye on that. As I said, up till November, for the number of samples that we have been able to sequence. And when I say we, I'm not talking just about the NCDC. We are not the only lab that's sequencing, but I was looking at the entire universe of samples that are sequenced from Nigeria. We've seen all of these other variants that everybody else had up to that time, and we are waiting to see all of the December samples, hopefully, to see what the scenario is. And it's for people to understand that there's a lag time. Testing occurs all across the country. People have to send those samples to where they need to be sequenced. They might come to us and we may either do them or distribute them along in the network. And sometimes some batching is necessary. I'm just giving you the numbers. There's only 48. All 48 samples were not tested by PCR to start with. So it means you have a smaller, some are RDT, some are PCR. You can only, because of the differences in the way method of collection, you can actually only sequence the PCR tested samples, and not all positive samples qualify for sequencing.
Oh, okay.
And then you'll have consumables that maybe, if you look at some of the tests you do, maybe each plate is meant to run 50 or 100 samples. These are very expensive things. You don't run every 10 or 5 samples. You also want to wait to batch things a bit. So we tend to get the comparison, oh, they are doing this in the UK, US. I think it's important we realize we are not the UK, the US. Even the South Africans who are doing well, who were the first to detect Omicron when it came out. This is second week of January. They are just giving you the results for December. Okay, and if you look at the detailed results, you will see that some provinces are even behind in sort of their sequencing and samples. We aspire to do better, but the fact that we are not you can't make the perfect the enemy of the good, is that we are keeping track the way we can. We are not complacent, regardless of what the headlines say. We are always doing what we need to do behind the scenes. I said this even when monkeypox came up. Suddenly people were asking us about monkeypox when the international outbreak happened. And I was asking them, I hope you know that, I said to them, I hope you know we have been dealing with monkeypox every year since 2017. The fact that you didn't pay attention, but now the rest of the world is paying attention, didn't mean that we were not doing our jobs. So that's the scenario there. We will continue. We recognize that it will always be important to improve on how we communicate with the citizens that we serve, because we want to, of course, maintain that trust and make people understand the reasons for why we do what we are doing. There's a general mistrust for government, and typically people sort of don't believe or expect the worst for government. But I don't think this is the case for this agency, which is part of government. And I think from even during the COVID response and before my time, we've always prioritized proper communication and engagement with the public to the extent that we can.
Okay, so we're due for a break, but before we go on that break, I'd like you to just allay that fear. So you actually mean that this new variant that you see in the UK, in the US, in China, in South Africa, Nigeria has nothing to worry about?
When you say Nigeria has nothing to worry about, what do you mean?
Because we've actually seen some people say that we're trying to allay the fears and trepidations. Some people just say that with all of this new variant, so does it actually mean that if I travel to this part of the country, or if someone comes in, does it actually mean that we could have something to worry about?
At the moment, we don't think so. There is no evidence at the moment. As you know, with COVID, it's an evolving situation. Things can change or not. But at the moment, we are not worried, as in worried to say we now need to put in other restrictions or change travel, or we are not.
Okay.
If we see evidence to do that in 1 week, 2 weeks, 3 weeks, we may do that.
Okay.
But as I said before, the concerns about maybe going back to the days of lockdown, that is just extremely unlikely, given the trajectory of this condition. But as I say, COVID is not over. Hopefully we don't have any more surprises, but surprises or not, compared to 2019, this is 2023, the world is not in the same place it was in 2019 and 2020. So I think that's an important thing for people to remember.
All right, so we do for a break, but before we leave for this segment of the show, just remember that he said COVID is not over until it is over. I'll see you shortly. Respond to Lassa Fever, do we have any reason to worry? The new reports we get.
So we have plenty of reasons to worry about Lassa fever. As you know, Lassa fever is a condition named for a town in Nigeria. Okay, we've had it for a long time. It's been largely neglected. We see it throughout the year, but we have a seasonal increase, typically between November and May, with about a peak period in February, which is the dry season. So basically what happens is the virus has a natural reservoir, a type of rats and other rodents, normally in the bushes, but in the dry season, because the bushes dry up, also human activity will go and burn the bushes. So the rats come closer to us to find food. And often our environments are not clean enough. There are heaps of refuse here and there, and so they have places to stay, and then can come into grab lunch, dinner, breakfast from your house, and then go back. But in doing that, because they are chronically infected with Lassa fever virus, although it does nothing to them, is that all of their excrement, urine, and everything else contaminates both surfaces and all of our foodstuff. Then we go and consume the foodstuff, and then we get infected. Okay? So we are already in the seasonal increase in Lassa fever has started already. We sadly have already seen the death of a healthcare worker or doctor. So my advice is, as we've continued to advise, at community level, please keep your environment clean. Try and rat-proof your homes by blocking access to that. But more importantly also, the things that attract the rats into your homes is food. So manage food and foodstuff properly. Store them securely away from where the rats can access them. Okay. Similarly, our traditional food processing processes that sort of involves leaving intermediate products around on the roadside or all of that where rodents can access them needs to be stopped.
Welcome back. If you just joined us, this is The Conversation. We're reaching you from KAFTAN's television here in the nation's capital, Abuja. You just joined us, you've actually missed out on a whole lot, but then you can still join in the conversation. Our guest on the show today is Professor Adetifa. He is the DG of NCDC. All right, before we went on that break, we've actually helped us to allay a lot of fears. But now let's talk about the COVID-19 vaccine. What kind of response are you getting from the people with regards to the vaccines, and how have you been able to allay those fears and misconceptions that came forth during when the vaccine was introduced?
I think it's important that, of course, one highlights that the NCDC is not responsible for vaccination. That's the mandate of the MPHCDA, but of course we support them in messaging and everything else that has to do with vaccination. As you know, with the pandemic, there was a lot of misinformation. Even when vaccines became available, there's also a lot of associated misinformation, or infodemic as we call it. People misinterpreted the speed with which vaccines were developed to mean that the world cut corners, rather than sort of commending this scientific development or achievement, and so on. And of course, with social media, with conventional media, Nigeria was not exempt from that. So we worked on, along with everybody else, on ensuring that people got the right messaging. You will notice that when the vaccination campaigns were launched or relaunched or so, everybody from the president and co were vaccinated in full glare of TV. When the Skills 2 was launched, Skills 3 was launched, the SGF received its second or third booster on TV, along with in the hall there, in the glare of cameras, along with the minister and even the executive director of the NPHCDA, just to inspire confidence. We also know that some of the attitude towards the vaccine is also driven by the low risk perception by many people in Nigeria who think, okay, we didn't die the way everybody thought we would die. I've had COVID before and I just had the mildness and I was fine and all of that. But we continue to encourage people. So, we are in a phase where we ease restrictions. People thought COVID had gone and all of that, but we're seeing what's happening in other parts of the world as a reminder that it's not over until it's over. And so we continue to encourage people. If you're concerned about what to do, the solution is not banning travel. Okay. Even when you ban travel and all of that, these are temporary measures to allow you to do something else. Okay? But a lot of that happened in the early days because the something else was developing vaccines or achieving enough vaccination coverage or enough population immunity so that when it finally comes, this will happen. I mean, the classical example is, if you remember, the island nations of Australia and New Zealand basically stopped everybody from coming home. Their citizens were stranded in different places all over the world. Okay? They did that and had very little COVID. Okay? I mean, a few imported cases here and there, people made it in. But then opened up when vaccines became available and started doing their best to get as much of high vaccination coverage as they could. So those measures cannot be done forever, and that's what China is realizing now, is that you can't, basically what the Australian and New Zealand government put in place was also a zero COVID policy, more or less, to protect the mainland. So these were temporary measures, but the thing to do to protect ourselves, let's ensure immunity, get vaccinated, get your booster doses, get your second booster. If you're in a high risk group, public health safety measures. If you have family members and friends who are the high risk group, contribute to protecting them by also you, despite your low risk, practicing the public health safety measures as well. This is really all we need to do. And the rest of us will continue to keep up surveillance, to keep watching what's going on at the ports of entry, to make sure that if anything changes and new interventions are necessary, then the Ministry of Health and all of its agencies and partners can do what's necessary.
All right, still on that politics of vaccines. Now, I know that you are research, that you have an interest in vaccine impact and effectiveness studies, and then you also also in innovative approaches, surveillance tools for monitoring vaccination, tuberculosis, epidemiology, and evidence synthesis, including systematic reviews. Now, with regards with all of these conceptions, and then people saying that HIV and AIDS have been there for decades, and then we've not been able to develop a vaccine. Do you actually, and then now COVID-19 just came, and then like just in a whip of a finger, we're able to get COVID-19 vaccine. So now, one on the side, do you actually think that would ever be able to develop an HIV vaccine ever? That's one on the side. And then secondly, how possible is it for Nigeria to develop its own vaccine, COVID-19 vaccine?
Okay, so there are two things. There's the need for people to understand that the pathogens are different. Okay. So HIV, malaria are different pathogens compared to, say, COVID, the virus that causes COVID. Okay. In part of my previous life, I did mainly TB epidemiology work. We did a lot of work trying to understand the correlates of protection or susceptibility to TB, all in a bid to be able to provide information that would feed into vaccine development so that it can address. If you know what makes people susceptible, then you can develop something to take that away. Or if you know what makes people protected, then you develop something to put that into place. So it's not because there's not been efforts to try. A lot of money and trials have been done in the TB field, and so far all of the vaccine candidates have simply just failed. Why? Because the bug, the bacteria that causes TB, for example, is a really complex one. One that, for example, has a complex covering that prevents our immune system from recognizing it properly. And despite all of our research, we still haven't found a way of cracking that particular bit. Okay? It grows very slowly. It multiplies only once in 24 hours. You need and which is part of why TB treatment takes months. Because a lot of the drugs that we give people are dependent on the processes that bug requires to reproduce. Okay, so when it's reproducing, it takes up your medicine. The medicine blocks one or two things there, and therefore it cannot finish manufacturing new babies.
Oh, okay.
Okay?
Okay.
Now, when you have a bug who only gives you that opportunity once in 24 hours, it means that you have to give treatment for a much longer period. The complexity of its covering, apart from making it difficult for our immune system to recognize and attack it, also prevents drugs from getting in. Okay? And although the bacteria, it's a bacteria that causes TB and it's a parasite that causes malaria, in terms of that complexity not being properly recognized by the immune system and all, they're actually similar.
Oh, okay.
Okay, so they have had exactly the same challenge with the world developing a vaccine to respond to them. It is taking how many years for us to get this current malaria vaccine, which, when you compare it to many of the vaccines we give in the childhood immunization program, it's nowhere as effective as them. But because there's such a huge burden of malaria, if you had anything that is 30% protective, you are taking off, reducing significantly
a huge
amount. So similarly with HIV, in fact, just like TB has something we call latency, which means it can be present somewhere in your body, stays there for the next 20, 30 years, and maybe in the 31st year, for some reason, it emerges, it multiplies, and then you have TB.
Okay.
HIV is similar. You get it infects people, does its work quietly in the background, and you don't know anything is happening till your immunity has really been brought low. Also, complex bug, infects our soldiers. That's the cells that our immune system uses to fight or to orchestrate our immune protection is what HIV targets. Enters them, takes over manufacturing, and makes them produce more HIV particles. Okay, so there's been quite a bit of success in HIV. It's now been turned to a manageable, treatable condition, even though you need your treatment for life, which sort of made the outlook significantly better. Again, equity of access to treatment and all of that is something that we saw and still see with HIV, but things are much better. So people have tried. Now, for some of the other bacteria and the virus that causes COVID, it was easier. They're not that complicated. It was people were able to quickly see what part of this virus is responsible for disease and therefore targeted by our immune system. And once they did that, they just used different methods, took bits and pieces of it, put it in a vaccine, or took the intermediate part. So when you hear about mRNA vaccines or so, what it means is we have mRNA in us normally. Okay, as part of this process of the body synthesizing or manufacturing proteins. In that chain, there's somewhere where mRNA is, and what it does is it goes to the final part of our cells that needs to produce something and gives the final instructions. So what people basically did was to put the part of the SARS-CoV-2 virus that is responsible or that stimulates an immune response on an mRNA, so that what it does is that then the body recognizes it and produces antibodies. Okay. But the mRNA vaccine platform has been available for more than 10 years before COVID came along. People were trying it for cancer treatments, other treatments. So it wasn't new. But the process of vaccine development or drug manufacturing, when you leave it entirely in the hands of people doing business, they take a risk-based decision in terms of deciding what to invest in. Okay? What the governments of the world did is to say, you know what? If you're able to make a vaccine that works, we'll buy 100 million doses. That reduces your risk. It's not, it completely reduces your risk. It's not like when you are working by yourself, you have shareholders and all of that. You want a product that ultimately, because a business is, you want to develop a product that works, that will be purchased, and you'll be able to pay your shareholders. You know that on that pathway, some products will not work. Okay? But you now have a situation where there's huge capital potentially available. Say, you just produce the product. We will buy it up for the next, I don't know how many.
XYZ
Yeah,
years.
XYZ
Okay.
years. So people bought in advance. So people worked quickly.
Okay.
But then we also had an urgent situation, because people seem to forget, although we weren't as affected, is that people were dying in tens of thousands in other parts of the world. There was an urgent need to have functioning vaccines, and people, they worked according to that urgency to save lives.
Okay.
Okay.
All right. So for the last other one, would Nigeria ever produce its own vaccine?
So, you know, historically, Nigeria used to manufacture vaccines. Okay. So it's not as if we never had the capacity to manufacture vaccines. I mean, of course, there were yellow fever vaccine is a different type of vaccine and all of that. But we had capacity. We had capacity just like the Institute Pasteur in Dakar that never had interruption in its manufacturing of yellow fever, whereas we did, and then sort of things broke down and we never recovered it. So that capacity is there. What has happened is because of years of neglect, poor funding and all of that, we lost the capacity to do that, and now we have to relearn.
Okay.
The world was able to develop COVID vaccines not because government Ministry of Health or government agencies had vaccine candidates waiting. The research community, who have been doing research in the background, had products that, or potential candidates that they could take forward. And once they had a potentially successful candidate, they then formed partnerships with pharma to manufacture at large scale. So, which is why, whether it's the story of AstraZeneca or the story of the Pfizer vaccine, smaller companies or other individuals were involved. They developed things up to a certain point, and once they needed larger capacity for manufacturing or more financing, they teamed up with pharmaceutical companies. And of course, many of these developers and small companies were affiliated with universities. So, and as I talk about ecosystem approaches, you need investments in education. All of your science and your STEM students. You need investments in universities, in labs. People need to be working with cutting edge technology and doing innovative research to be able to get to the point where you even identify candidates for vaccine. Of course, along with government research institutes, because the space is big enough for all of you need all of the players. Okay, so what would happen if we begin to fill up those gaps is that then we place ourselves in a better position to develop vaccines that respond to our problems.
Okay.
Okay, because let's forget about COVID. Is until for 40 years or longer, nobody tried to develop a Lassa Fever vaccine. Meanwhile, we had most of the cases. Okay, until recently, where with more attention and more willingness and engagement by governments and including our agency and others, there's been an effort. We need to develop our own diagnostics so that we don't wait for people to import vaccines. I mean, part of the lessons from COVID is, even when you had your money, things were not available.
Exactly.
Okay? So beyond vaccines, we need diagnostics because you need to correctly identify condition. You need to identify treatments. Not everything, vaccines are not magic bullets for every condition. Some people will still come down with what you have vaccinated them against. You need to treat them. Okay, but if you're also fully dependent on importation either of all of your raw materials or even you import the final product, then you have an issue. So all of this increased recognition and new investments that have been made by this government and hopefully will be continued by other governments will place us, and of course the interest of WHO and others in regional hubs will bring us closer to doing that.
All right, but just before we let you go, I'd like you to respond to Lassa Fever. Do we have actually any reason to worry with the new reports we get?
No, we have plenty of reasons to worry about Lassa fever. As you know, Lassa fever is a condition named for a town in Nigeria. Okay? We've had it for a long time. It's been largely neglected. We see it throughout the year, but we have a seasonal increase, typically between November and May, with about a peak period in February, which is the dry season. So basically what happens is the virus has a natural reservoir, a type of rats and other rodents, normally in the bushes, but in the dry season, because the bushes dry up, also human activity will go and burn the bushes. So the rats come closer to us to find food. And often our environments are not clean enough. There are heaps of refuse here and there, and so they have places to stay, and then can come into grab lunch, dinner, breakfast from your house, and then go back. But in doing that, because they are chronically infected with Lassa fever virus, although it does nothing to them, is that all of their excrement, urine, and everything else contaminates both surfaces and all of our foodstuff. Then we go and consume the foodstuff, and then we get infected. Okay? So we are already in the seasonal increase in Lassa fever has started already. We sadly have already seen the death of a healthcare worker or doctor. So my advice is, as we've continued to advise, at community level, please keep your environment clean. Try and rat-proof your homes by blocking access to that. But more importantly also, the things that attract the rats into your homes is food. So manage food and food stuff properly. Store them securely away from where the rats can access them. Okay. Similarly, our traditional food processing processes that sort of involves leaving intermediate products around on the roadside or all of that where rodents can access them needs to be stopped or reduced, because if those things are contaminated by the rats, then it means that the consumers are likely to get infected.
All right.
The other thing is when people develop febrile illnesses, of course, people make diagnoses. I have malaria. This is how I feel when I have malaria, or this is how I feel when I have malaria typhoid. Please, fever is a symptom for many illnesses, including self-limited ones that are caused by other viruses. Present to a health center, ensure you are tested so that if the tests for the more common conditions are negative, people can begin to think about whether you have Lassa fever and immediately try and make a diagnosis and institute early treatment. Early presentation, early treatment are directly related to having a good outcome. If you present late or diagnosis made late, then outcomes are poorer. Finally, to our healthcare workers, our colleagues who are on the front line who look after patients, please protect yourselves. Please make no assumptions about what the client or patient in front of you may or may not have. Assume it's the worst thing. They have Ebola, they have Marburg, and protect yourself appropriately in looking after them. Because part of what happens, and we don't want healthcare worker deaths, is that you get patients to present to health facilities, they infect the healthcare workers, and suddenly you have a bit of a hot spot even in the hospital because other patients will be seen. Our healthcare workers are very valuable assets. Okay, we are complaining about brain drain or maldistribution of healthcare workers. For every sort of senior, junior, doctor, nurse, pharmacist that you lose in a facility, that's a significant gap that would affect all other care, not just whether it's in the pediatric section or not. And you know how difficult it is to also even hire replacements and all of that. And you know what the impact would be on the morale and psychology of all that. So it's important that we protect ourselves as healthcare workers to be able to do the good service that we provide to our fellow citizens, basically.
Thank you so much. What a fine place to end this conversation. Thank you so much, Dr. Adetifa. It's been a wonderful time having this talk with you.
Thank you for having me.
Great. All right, viewers, that's where we end the conversation. We have been chatting with Professor Ifedayo Adetifa. He is the DG of Nigeria Center for Disease Control. And it's been a wonderful time here on The Conversation. Keep watching The Conversation because you never know who my next guest will be and what my next topic will be all about. Till I come your way again from the nation's capital, Abuja, I am Annabel Orji. God bless you and yours, and God bless Nigeria.